So, guys, welcome to our 5 minute masterclass on the cardiac anatomy. To understand the heart, one must first understand its orientation. The heart doesn't simply just sit in the chest, it is tilted with the base positioned superior and posteriorly, while the apex points inferior and to the left. This orientation is, I would say, key to localizing specific pathologies, and we'll come across that on the course of this discussion. I know some of you might find it a bit difficult understanding what I mean by anterior, posterior, medial, or lateral, or even superior. So I'll create another video where I explain the axis and planes, and anatomical axis and planes in general. So now let's look at the right side. Let's begin with the structures of the right side. Beginning with the right atrium. This is a collection hub, I would say, receiving deoxygenated blood from the entire body. This is done via the superior vena cava and the inferior vena cava. So the right atrium also receives deoxygenated blood from the coronary sinus, which drains the heart. Critically, the SA node as well, which is the heart's natural pacemaker, is situated right here at the junction between the superior vena cava and the inferior vena cava. Just below is the right ventricle. Because it is the most anterior part of the heart, it is the most susceptible to blunt chest trauma and sometimes even penetrating chest trauma, such as a knife wound to the chest or even a steering wheel injury in the car accident. I want you to take note of that. It's a very important clinical pearl. Exams love that. Let's look at the left side. Beginning with the left atrium, it is the most posterior chamber. Its position is clinically vital in such sense that if the left atrium enlarges due to an increase in the cavity pressure, this is typically occurs in mitral stenosis, which is a stiffening of the mitral valve. That is the valve between the left ventricle and the left atrium. So this can cause a sort of backlog and building of pressure, which over time causes the left atrium to enlarge. Now, this enlargement can compress the esophagus, causing a case of difficulty swallowing termed dysphagia. Or this enlarged left atrium could even compress the left recurrent laryngeal nerve, leading to hoarseness of voice, a condition commonly known as Ortner Syndrome. Finally, we have the left ventricle situated just below the left atrium. This is the thick-walled powerhouse that forms the cardiac apex, does most of the pumping of oxygenated blood to the entire system. Now, moving on to the great vessels. So, these handle the heavy lifting of entry and exit of blood into the heart, which are the aorta, this giant arc of a blood vessel exiting the left ventricle, carrying oxygenated blood, and the pulmonary trunk exiting the right ventricle, carrying the oxygenated blood to the lungs for subsequent oxygenation. Now, here's your high yield fact, guys. The aortic isthmus, which is located just distal to the left subclavian artery, is the most common site of injury in rapid deceleration trauma. So, this occurs when a body moving at very high speeds suddenly stops. The heart moves, but the aortic arc is fixed. So, this puts significant shearing forces on the aorta, leading to a potentially fatal aortic transection. Now, some very important set of structures, the valves. So, these ensure that blood moves in only one direction. I sort of like to group the valves as the atrioventricular valves and the semilunar valves. Beginning with the atrioventricular valves, so these generally are situated between the atria and the ventricles. They are the tricuspid valve between the right side of the heart, that is the right atrium and the right ventricle, and the mitral valve, which is situated between the left sides of the heart, which is the left atrium and the left ventricle. Now, these valves are anchored by the so-called heartstrings or termed chordae tendineae and the papillary muscles to prevent backflow of blood. Now, this is clinically important as in some cases, rupture of the papillary muscles or the chordae tendineae in some case of myocardial infarction could cause a sort of regurgitation of blood. Now, the next group of valves are the semilunar valves, the aortic valve within the aortic trunk, and the pulmonary valve within the pulmonary trunk. This basically guards the exits. So, valves typically have leaflets. Remember, it's very important to know that the mitral valve is the only valve with just two leaflets. All other valves have three leaflets. Next thing I would like us to know is the layers of the heart wall. So these are really clinically significant. So I want you to think about the heart wall in three layers. The endocardium, which is the most inner lining, the the myocardium, which is the muscular layer, does most of the contractile function, and then the epicardium, or I would call it the visceral pericardium, is the outer surface. This typically gets involved in the cases of pericarditis. So, guys, let's conclude with a rapid review of this high yield table. We have here the right ventricle is the most anterior portion of the heart, most commonly involved with traumatic, blunt or penetrating injury, injury such as a knife wound to the chest. The left atrium, which is the most posterior portion of the heart, typically enlarges and causes dysphagia and Ortner syndrome. The mitral valve, which is a two-leaflet valve, the only two-leaflet valve, as I said earlier, associated with mitral valve prolapse, which presents as this mid-systolic click on auscultation of the precordium. And finally, the coronary sinus empties into the right atrium, and it is the largest vein of the heart carrying the oxygenated blood. Again, I would like to mention that the transesophageal echo, where a probe is inserted into the esophagus to visualize the left atrium and the mitral valve, truly gives us the best possible view of these structures due to the close association of these structures to each other, of how close they are to each other. I mean, all right, guys, thank you for listening in and thank you for watching. Until next time.